Okay, started. Okay, we'll continue with our last lecture in immunology. Immunology part is over after this. We went over the immune system and how, just sort of briefly, went over how a defect at different stages has been observed. And these defects are genetically passed on, and therefore they are part of the primary immunodeficiency diseases. We'll continue and go on to the very base here, and the first one is the reticular dysgenesis. That results from a stem cell defect slightly above the beyond the platelet and red cells. So these patients have got red cells, normal red cells and platelets, but they do not have any of the lymphoid cells. And there are very, very few cases. So it's almost like just you have got to know that it exists. You're very unlikely to come across a patient with reticular dysgenesis, but you never know. Okay, and these patients, obviously, if they do not have any T cells, any B cells, any neutrophils, any monocytes, macrophages, they're extremely susceptible to all infections, and they don't survive beyond a few weeks. They have no. If they do not have any T cells or B cells, they will not have any immunoglobulins either. So you just have to bear that in mind. What is the consequence of a defect at a particular stage in the development of the immune system? T and B cell defects, they combine, and that appropriately is known as severe combined immunodeficiency. These patients do not have any T cells or B cells, and therefore no immunoglobulins and no cytokines, production of the cytokines that are produced by T cells. They will not have functional NK cells either, because the functional NK cells would require that they are activated by IL-2 or an interferon gamma, which are products of T cells. Some of these are X-linked, and their mechanism of the defect site at which their lesion occurs is different from the ones that are autosomal. In the case of X-linked immunodeficiencies, the defect is in the IL-2 gamma chain peptide gene. If you remember from Dr. McCaleb's lectures, IL-2, there's different varieties of different kinds of IL-2 receptors. The low affinity receptor and the very high affinity receptors. But the gamma chain is part of the IL-2 receptor. Not only that it is a part of IL-2 receptor, but it is also shared by other interleukin receptors like IL-4, IL-7, IL-11, and 15. Okay? So a defect in gamma chain means all those receptors are defective. And these receptors are involved in the proliferation, activation and proliferation of T cells. Okay, and production of IL-2 and interferon gamma, because if the T cells are not activated, they are not going to produce any of those either. So consequence of that is lack of both T and B cells. The autosomal kind of severe combined immunodeficiency, there are several reasons why this defect occurs. One of them is lack of adenosine deaminase and purine nucleoside phosphorylase. These enzymes are involved in detoxification of the adenosine as well as purine in their pathway. And the lack of these enzymes results in toxicity in both T and B cells, and these are killed off before they differentiate into functional T and B cells. And consequence is, of course, lack of T and B cells in these patients. Another one, RAG1 and RAG2 defect. If you remember, we talked about several times in the during the course. Dr. Mayer talked about them, and I refer to them as well. These are proteins involved in the rearrangements of BCR and TCR, and I'm on purpose saying BCR, B-cell receptor, which happens to be immunoglobulin, okay? But that is the receptor that is responsible for B cells to recognize antigen, and after recognition, there is a cross-linking of that receptor, and there is a signal delivered for the B cells to proliferate. If there is no RAG gene, there is not going to be any rearrangement of the BCR or TCR. As a result, there will be no positive selection. And if there's no positive selection, there's not going to be any cells coming out of the thymus or the bone marrow for B cells. So there is lack of B and T cells both as a result of defective RAG1 and RAG2 genes. Another one is IL-2 receptor. The alpha chain of IL-2 receptor is also autosomal immunodeficiency, and this is not as severe as, of course, the gamma chain, because gamma chain is shared by other. But the alpha chain of the receptor is the high affinity receptor, and a defect in this also results in the lack of or deficiency of both T and B cells. So these are the various defects at the genetic level that can lead to lack of T and B cells in these patients. Now, I do not have to expect you to memorize which one is X-linked and which one is autosomal. Okay? That is there for completion's sake. I'm not going to ask you, you may find it some other places, so have that information. Yes? You had a question? Yeah. As a result of IL-2 receptor defect, okay, IL-2 receptor defect, there is not going to be any activation of lymphocytes. They are not going to be able to interact with IL-2, and as a result, there will be no proliferation, activation, proliferation of these cells. Therefore, there will be no expansion of clones. Okay? Does that make sense to you? Okay. Any other questions? Okay. So these are the lesions that can lead to severe combined immunodeficiency. Because of lack of T cells and B cell proliferation and expansion, these individuals will not have a very well developed thymus. As a matter of fact, thymus is nothing but a sheath or a sac filled with T lymphocytes. Okay? The epithelial structure is very, very, very small compared to, the number of cells that occupy the spaces. So, as a consequence of having no T cells, there will be no development of T cells. There will be very, very small shrunken thymus, just very rudimentary, and therefore on X-ray it's not going to come up. Okay. There will be lack of T cells as well as B cells. So lymphoid organs are going to be even secondary lymphoid organs are going to be very poorly developed. And you will see in a little while some histological slides. There will be no immunoglobulins of any class or subclass because there are no B cells to start with, no primary follicles, and no germinal centers, which are a result of expansion, the activation of lymphoid cells, B cells, lymphoid hypocellularity of tonsils, and Paris patches will be a characteristic feature of these individuals. They will be extremely susceptible to all infections, to be bacterial, viral, or other pathogens. That's why those babies are kept under various sterile conditions, and sometimes they are referred to as bubble babies, which you probably have heard of. Okay, one of the things that you should deduce from what you have learned, obviously live vaccines are living organisms that have been attenuated. But it doesn't matter how much you attenuate any organism, if there's no immune system, they are going to be pathogenic. Just like the AIDS situation that I described, they are susceptible to all infections. So anytime you see immunodeficiency, particularly of severe kind or T-cell immunodeficiency, you've got to stay away from live vaccines. There is no point in immunizing these patients anyway, but if one suspects immunodeficiency, severe combined immunodeficiency, one has to particularly avoid any live vaccines. Okay? Now, there are a few of those. This is what organ might it be? Thymus, it says there. One of the lobes of thymus. Okay. As you can see, the lobes of the thymus, they're filled with cells, and they have got a particular sort of structure. They're structured, whereas the severe combined immunodeficiency thymus, if one looks at it, is characterized by lack of cellularity. Okay, very, very few cells there. The stem cells are going to come there, but there are not going to be any proliferation because of positive selection. Following positive selection, there will be hypocellularity of the thymus. And there will be, the structures, cortical medullary structures will be disrupted. Okay, the lymph nodes, that's a normal lymph node, whereas you can see that there is a, lack of cellularity in the both T-cell and B-cell dependent area, meaning cortex and medulla, both of them are hypocellular. They do not have very many cells. And you will see that in your POPS exercise as well. Some of these histological presentations. Okay, the tonsils, normal, whereas the abnormal, this structure is totally different. Same way. I think the turning off the lights might help a little bit better for people at the back too. Okay, if I can. Okay. All right. Okay. If one looks at the Pierce patches, that's a normal Pierce patch, and whereas abnormal is, lack of cellularity in this area. Okay. If one looks at you have all seen that slide before, right? Or something similar. This is immunoelectrophoresis of serum, whole serum, and then developed with antibodies against all the serum proteins. But you have got to pay attention to only in this area where all the immunoglobulins migrate. If you remember the basic principle of electrophoresis or immunoelectrophoresis, one puts the samples in these wells, applies the electric current, and the albumins migrate to one side, and the immunoglobulins quite the opposite side, towards the negative pole, and towards cathode, and the different immunoglobulins being different sizes, they are going to diffuse at different rate and combine with the antibody in different places. Okay, IgM being the largest one will stay very much close to the origin. And in this case, here is the IgM line, very close to the origin here. Here's the IgG line, and since IgG is in abundance, that line will be the thickest line. Okay? That line will be the thickest line. And IgA, being very similar, serum circulating IgA, will be very similar to IgG, but different charge, and it is represented by this spur here. Okay? This branching here. So M, A, and G, those are the three, and there's very little E and D, therefore you don't see any lines for those. that they cannot be detected by this particular technique. What is important now to look at which one is normal? Obviously, there is a normal component of G, A, and M in this sample, and they are lacking, all of them are lacking in this sample at the top. The patient's serum here, normal serum here, and you can see the lack of immunoglobulin. So if you see this pattern, don't be surprised, okay? And you should be able to work out what is lacking in this particular case, okay? So all the immunoglobulins are absent. One can measure. That is the clinical test one applies to further diagnose or confirm the diagnosis in these patients. One can enumerate, of course, T and B cells in the circulation as well, and there will be very few. And that is done by immunofluorescence, flow cytometry. Dr. Mayer described that when he was talking about tests for antigen-antibody reactions. Okay? Immunofluorescence meaning they are stained with anti-immunoglobulin or antibodies against T-cell marker, which is CD3. You stain them, and you can enumerate and confirm the diagnosis by seeing very few or no T and B cells in these patients, and then immunoglobulins are absent as well. Okay, so that is the severe combined immunodeficiency, where both T and B cells are very severely reduced or absent, and consequences, absence of immunoglobulins as well. In your table, in your handout, there's a table that summarizes all the diseases as well as what's the defect in there. And what is another table there is that describes what is the consequence of a particular defect. If there's no T and B cells, no immunoglobulin, obviously there's a susceptibility to almost anything, any organism. But when there is a defect in T cells, if you remember from the Dr. McKelliff's lectures, he pointed out that intracellular organisms that grow inside the cell, they are gotten rid of. Immunity against that depends very much on cell-mediated immunity, and that involves T cells. So when there is a defect of just T cells, you can deduce from that, okay, these patients are going to be very susceptible to viruses that are intracellular, always, and some bacteria that are also intracellular. You will learn about them in the bacteriology section. And mycotic infection, fungal infections, and parasitic infections, they all depend on T-cell immunity. So T-cell defect translates into fungal and intracellular pathogens, susceptibility to those. And an example of T cells, purely T cell defect, where the B cells are normal, is a DiGeorge syndrome. It's a syndrome described by DiGeorge first, who observed these. And then there are some other conditions where different degrees of T cell defects are seen, and they are also accompanied by B cell defects. And these, the most prominent among these are Wiskott-Aldrich syndrome and ataxia-telangiectasias. And those are examples of T and B cell defects, but different, not as severe, not like severe combined immunodeficiency. They are like more sort of partial defect in both T and B cells. Okay. To go on to describe DiGeorge syndrome, there's a poor development or absence of thymus. It is not X-linked. As a matter of fact, the locus at which there is a defect is not, I've not seen it described at least. But what happens is that during gestation, when the thymus is developing, and that's around 12th week, 11th, 12th week of gestation, when the facial features are being formed, the heart is being formed, parathyroid is being formed, for some reason there is a defective development. And that defect can translate either one of the components or many of the components that are developing at that time. So in these patients, sometimes you see immunodeficiency, other times you may not see immunodeficiency. So the syndrome which components are defective varies from one to the next case. But typically, if there's a DGeorge syndrome where there is immunodeficiency or a lack of T cells, it will also be accompanied by other features resulting from improper development of the fetus. From the immunological point of view, T cells are absent or very low in numbers. There may be very, very rudimentary thymus or maybe partially developed thymus, and consequences partial or total defect in T cell numbers. Okay, the treatment I did not mention for severe combined immunodeficiency. I'll do that in a minute. But a thymic graft can correct the T cell defect. But it is also associated with the other defects due to aberrant development, and that may result in abnormal facial features. And I'll show you in a minute what those features are. It may be associated also with hypocalcemia, and this defect, of course, has got to be corrected by proper treatment, metabolic corrective drugs. There may be congenital heart defects. Aortic arch may be defective. The valve may be defective, and those can be corrected by surgical procedures. Okay. The facial features, were very characteristic features that have been described, is a sort of rounded fish mouth. Appropriately, Nemo is sitting there. I think that Nemo has lost his way. The colors tell us that he is in the wrong institution. Okay, any Clemson people can help? Oh, okay, you can perhaps help. Yeah, find the right place. Huh? He wants to be here, better institution, right? Okay, Nemo like the mouth, and then low set ears, relatively speaking, and they may be notched, those ears. And those are facial features. Okay. The hypercellularity of the thymus, one can use almost the same slide as before. Okay, poor development of thymic lymphoid areas. The lymph nodes will also be poorly developed because there are no T cells in the paracortical areas. It will be very, very poor development of T cells. There will be B cells in sort of follicle, but there will be no germinal centers because germinal centers come from memory responses, secondary responses, okay? And there will be, class switch requires, secondary response requires presence of T cells. Okay, so those are the features of that. The corrective measure is, of course, grafting of the thymus, thymic graft. But you cannot just graft any thymus because what will be the consequence of just grafting any old organ? Graft versus host disease, very good. There will be, consequence will be graft versus host disease. So one has to take a thymus that comes from a fetus where the thymus is formed but not populated with T cells. And that's around, 14th week of gestation. One can obtain these grafts from miscarriages or abortions, aborted babies. Okay, so that can correct the thymic defect. Okay, in the case of that severe combined immunodeficiency, of course, I have omitted to mention there the treatment will be gamma globulin treatment can work, of course. Immunoglobulins, but that will not be a permanent solution. Bone marrow graft or gene therapy has been used in those cases. Okay, if there's an ADA deficiency, one can use, ADA gene transfected cells, transfected bone marrow, and then they will be continuously growing. Okay. Ataxia telangiectasia, immune defects in this case, are a reduced number of T cells, and their functions are reduced. And how one measures the functions, one of the very broad and easy way of measuring T cell function is taking the peripheral blood and culturing them in the presence of a protein derived from a seaweed, PHA, it's a bean, from a bean plant, a bean seed, PHA, phytohemagglutinin. Okay? And the protein has the property of binding to T cells and activating all T cells, and that's referred to as polyclonal activation of T cells. And you will see that test in your POPS exercise. So phytohemagglutinin, or more often called PHA, just PHA. All immunologists know what PHA stands for. So they expect you to know it too. Okay, PHA, phytohemagglutinin, polyclonal activator of T cells. Another protein that is concanavalin A, and that is, I think, from a seaweed. If I remember right, you don't have to worry about where it comes from. Just con A or concanavalin A, that's also a polyclonal activator of T cells. Both of them are polyclonal activators. And one can use those for culturing blood cells, and if there's no response, obviously there's no function of T cells. The T cell may be there. Your CD3 count, CD3 positive cell count may be normal, but they may not respond to that. And it varies from one case to the other. Okay? There is going to be low IgG and IgA, because those are dependent on functional T cells. There's cross switch. So these will have very low IgA and IgG. Non-immune defect in this is ataxia, means lack of coordination. So hand to eye coordination is defective in these. And telangiectasis is leakiness of small blood vessels, and therefore there will be observed as well in these patients. Okay, so bloodshot eyes is another sort of example of that. Okay, the defect is in the DNA repair mechanism, particularly where there is a rearrangement, where immunoglobulin genes are and where the TCR genes. And there is a defect in the repair mechanism, so when they, perhaps, that's my speculation, they are rearranging the genes, they cannot, properly ligate them back again. Okay, break in TCR and Ig heavy chain genes, okay? But that's the reason for, that's the molecular basis for defect in ataxia telangiectasia. Okay, if one looks at the electrophoresis, and I'll let you look at it, as you can see, the bottom one is normal, and if you look at the top one, what do you see missing or abnormality? IgG is very much thinner line, so there's a reduced amount of IgG. There is IgM there, line there, no IgA spur there. Okay? So that's how one would characterize or test their defect in their serum immunoglobulins. Okay, so that is ataxia telangiectasia. As for treatment, gamma globulin treatment, infectious treatment, there is no particular treatment like ADA or deficiency or severe combined immunodeficiency, or in the case of DiGeorge syndrome. And all the rest of the defects, immunological defects that I'm going to talk about, the treatment is really gamma globulin or immunoglobulin treatment in those cases. So if I forget to mention those, that's what it would be. Okay, immune defects in Wiskott-Aldrich syndrome are T cell may be normal in number but reduced in function. Same way as Wiskott-Aldrich. Ataxia telangiectasia. Okay, the abnormality is low IgM, but they have normal IgG and elevated IgA and IgE for some reason. How that defect is explained, I have no idea. Okay, So, but they're lower IgM levels, but normal IgG and IgA and IgE are elevated. Consequence of IgE elevation is the atopic symptoms, allergy symptoms, of course. And that is what does happen in these cases. They respond poorly to polysaccharides. Polysaccharides are T-independent, mostly IgM. IgM is low, and therefore they will not respond so well to polysaccharides. And consequence of that would be susceptibility to infection, where antibody response to polysaccharides are important, and that would be pneumonia, pneumococcal pneumonia. You will learn later on that and from the immunization lecture, you should remember that the vaccine there is polysaccharide, okay? So they will respond very poorly to pneumonia, pneumococcal vaccine, and they will be susceptible to pneumonia, yes. IgE, immunoglobulin E. No, more atopic conditions. I'm talking about the less resistance to pneumococcus because they are low in IgM. And most of the response to polysaccharide vaccines is IgM because it's a T-independent antigen. Okay? Is that? Okay. Come back to the question if you can't resolve it. All right, so there is a poor antibody response to polysaccharides in these. They are, since there's a functional defect, they are poor in polyclonal response to PHA and CON-A. Those two proteins are also referred to as lectins. Okay? Lectin are proteins that bind carbohydrates. Okay? Carbohydrate binding proteins. But PHA and CON-A are put in that group of proteins that are called lectins. So if you see lectin in terms of immunological context, think of PHA and CON-A. Okay, non-immune defects in these, eczema and petechia, because that is associated with high IgE levels. That's what I was referring to. Okay, thrombocytopenia and defective platelets are observed in these patients as well. And there is a defect in a protein called Wiskott-Aldrich syndrome protein. So that's like chicken and egg, which came first. As a matter of fact, Wiskott-Aldrich syndrome as an immunological defect was described first, and then this protein was discovered later. And this protein is involved in cytoskeletal reorganization. And somehow that translates into immunological defects. Don't ask me how. Okay? But there is a defect in WASP protein, WASP, and that is associated with a cytoskeleton reorganization defect as well. Treatment, again, gamma globulins, okay, to keep them, and keeping better eye on their vaccines, because they do have a few T cells and functional maybe subnormal, but they can respond. If one looks at the immunoelectrophoretic pattern, one finds that normal IgG, IgA is there as well. IgE you cannot detect by this method, even if they are elevated, so it's not represented there. But there is a IgM line in this one. Okay, IgM the closest to the origin. That's how you can remember where IgM is going to be represented in immunoelectrophoretic slides. Okay, so those are the T cell defects that are directly involve T cells and B cells. Then there are some syndromes described in the literature where it's not a direct defect in the T cells, but there is a defective MHC production. And if you remember the positive and negative selection process in the thymus, okay, How are they selected? They are selected on the basis of self-MHC plus peptide, recognized by the T cells as they are producing their their TCR. Okay, they are expressing their TCR, low levels of TCR. They interact with MHC self-peptide and positively selected. And after that, they are negatively selected after further differentiation. Well, if there's no MHC to be recognized by those cells that are on the way to differentiation, they're not going to differentiate. Okay? And there are conditions where there is a defect in MHC molecules. It could be even beta-2 microglobulin. If there is a defective beta-2 microglobulin, what will be the consequence of that? It will not, what? Complete that thought for me? That's right. It will not associate with the MHC1 alpha chain, and that molecule does not fold properly to be transported to the cell surface. So the cells will not have class 1 MHC. Okay? And such defects have been described in some immunodeficiency patients that lack class 1. Okay? And likewise, class 2 MHC also is involved in selection of CD4 cells. Okay? CD4 cells. So in the case of class 1, there will be defect in CD8 cells. In the case of class 2, there will be defect in CD4 positive cells. Okay? And there the defect is a transport activator, transactivator, or a transcription factor defect. Okay? That is a protein that is involved in activation. Remember, the class 2 molecule is not constitutively expressed in all cells, but it can be upregulated by interferons and other cytokines. And this class 2 transactivator protein is involved in that transcriptional activation. So if there's a defect there will be poor expression of class 2 MHC molecules, and that will translate into fewer CD4 cells. In the case of class 1, there is a transport-associated protein that takes those peptides, cell peptides, to the endoplasmic reticulum, where the protein is being synthesized. Okay, and if there is no transport protein, these peptides will not reach there. If the peptides don't reach there, the class 1 MHC molecule will not fold properly, and it will not be expressed either. So those are some defects that have been described, in addition to the beta-2 microglobulin defect. And consequence is the same, either either CD4 or CD8 cells missing, depending on which MHC is defective. If there's the defective class 1 MHC, CD4 cells are fewer in number, and if the class 2 MHC is defective, then the CD4 cells are few in numbers. Okay, so that was the T and B cells both. Now we'll take a few minutes to talk about X-linked, the purely Ig immunoglobulin defects, and the most severe one of these is X-linked, also known as Bruton's hypogammaglobulinemia. Okay, and here there is and there are a few others that I'll just tell you about. Transient hypogammaglobulinemia is another one condition. There's a common variable hypogammaglobulinemia. There is selective IgA deficiency, selective IgG deficiency as well, and there is a hyper-IgM immunodeficiency. And those have been described, and what is the defect in those. In case I do not get to talk about all of them, what you have got to pay attention to in your handout is that what is the genetic defect and how it translates into immunological defect. Okay? And that has all been covered in the general immunology lectures. Okay, X-linked, characterized by low cell numbers, low immunoglobulin classes and subclasses of all immunoglobulins. And that is due to a tyrosine kinase that is very special, specific for B cells, and that B cell tyrosine kinase is involved in the differentiation or the, of those B cells. And due to that defect, they do not differentiate properly, and therefore there is no immunoglobulin synthesized. Of course, there are very few B cells differentiate to become B cells. So they get arrested at a much earlier stage of differentiation. Okay, the transient hypogammaglobulinemia is a condition that it is seen at in a certain window in the child development. Okay, if you remember from Dr. Mayer, he told you that newborn have got full component of immunoglobulin, but only IgG. IgG is the most abundant of the immunoglobulin, and they have got full components of maternal IgG. They do not have any IgM and IgA that they develop later on. And as the maternal immunoglobulin, IgG, decays, because of certain half-life, there is emergence of the newborn starts producing its own IgM first, then IgG, and IgA later on. And normally it sort of develops in this pattern, okay, between birth or between 3 months and 2 years or 3 years of age, at different rates in different individuals. But some children have some defects which is not very well characterized and defined, that there is a delay in this process of immunoglobulin synthesis by their own cells. And consequently, during this window between 6 months and a year or 2 years, they have very low immunoglobulin levels. Maternal has already decayed. They are not producing their own, but they catch up later on. And in this window, they are very susceptible to infections that involve antibodies, involves immunoglobulin. That means bacteria of different varieties, particularly extracellular bacteria. Okay, so that is, but they do catch up, and during that period, they can be given gamma globulin treatment. Okay. Then there is a acquired hypogammaglobulinemia, or is also referred to as common variable hypogammaglobulinemia. And again, for unknown reasons, certain individuals are genetically such that during the second and the third decade of their life, suddenly they stop producing immunoglobulins. And they come out of that phase later on, but during that period they have got to be treated with gamma globulin. Okay? All immunoglobulins decline, and most often IgG and IgA. And it is thought that they have some sort of class switch. Why in that age period? It's not really known. The cause is unknown. Okay, if one looks at let's preamble that. In addition to that, there are immunodeficiency of individual immunoglobulins, IgG, IgA, immunodeficiencies. And most common of these is IgA immunodeficiency. These patients have low levels of IgA. Consequently, they are susceptible to infections of the GI tract, nasal areas, and the pulmonary infections. Okay. If one looks at their electrophoretic pattern, again, you can see that that's a normal sample. The IgG line is here, the IgM line is here, and that little spur, it represents IgA, and if they have got IgA deficiency, of course, that would be missing in that patient's serum. Okay, hyper IgM, and that's probably the last one I'll get to cover. I'll leave you to go over the non-specific immune system as it is described there, okay, yourself. The hyper IgM syndrome is characterized by increased amount of IgM, as you can see from here, that's the thickest line here representing IgM, increased amount of IgM, but very much decreased amount of IgG and IgA. And obviously, if you think of it, development of the immune response that Dr. Mayer described and Dr. McKillop described, the IgM is synthesized first, and then there is a T and B cell interaction for a switch to another class. And which molecule is involved in that? Come on. Remember that class switch? CD40 and CD40 ligand. Okay? CD40 ligand is involved in that. And, of course, there is a defect in CD40 ligand in these patients. And that translates into what? They are going to keep on producing as they get infected. They are exposed to the environmental antigens. They're exposed to the different organisms, normal flora as well as other pathogens. Their immune system is being stimulated. They're going to produce more and more IgM. They cannot switch the class or subclass. And therefore, they will have lots of IgM, but little else. Okay? So those are the immunodeficiencies of the specific immune system. Read the non-specific immune system, and if you have got any problem, just yell at me, come by, send me an email, okay, and